We're going to have two folks talk to you a little bit about Interlace Health usage and real life usage in a hospital scenario. So we're going to have Dessiree, who is our Director of Product Marketing, and Rachel All. Rachel will tell you her title. It's I think it's the second longest one that we have, or that I've seen. But Rachel works with Akron Children's Hospital. They're about 300 beds, 400 beds. They're about 400 beds. I think it was 397. But they are a HIM7 shop. So they are rocking and rolling. They run a very tight ship. And when you hear Rachel talking, you'll know why. But they're going to give you a little insights about their experiences or her experiences with Interlace Health.
Hi, everybody. Like she said, I'm Dessiree Paoli. I'm the Director of Product Marketing here. If you guys have watched any of our webinars, you've probably seen my face or heard my voice. I wanted to share a story related to Chris's presentation because it always pops up in my head when I think about email attacks on hospitals. I worked at Children's Hospital in Colorado for 7 years, and one day we're just sitting in our open floor plans. You can sort of hear everyone across all the cubicles, and we all get this email at the same time, and it says, you know, there's a 5-year-old boy named Aiden. He's in the PICU. His parents brought his puppy by. The puppy got lost in the hospital. Click on this link to see a picture. And you just heard this audible gasp of women across, the floor, like, oh, the puppy. And of course, the cynics all jump up and they're like, don't click on the link, don't click on the link. But they really are evil people out there to use this little boy and this puppy, fictional puppy, to get you. But they will try anything. But I'm excited to be up here with Rachel today. I think if anybody's title says Forms Guru, it's yours. So do you want to tell us a little bit more about what you do at Akron Children's and the hospital in general?
Sure. I've been with Akron Children's Hospital for 6 years. I came there right out of school. And I went to school for Health Information Management Systems, so you might know why my title is really long. Really all that is like a bridge. It's medical records is what it is, but it's a bridge between like the healthcare and the legal and the IT side of the world. So medical records aren't just medical librarians anymore. We're really bridging that big gap. I started as the data integrity specialist, so I manage patient identity, chart corrections, things like that. And one day, I guess I was kind of bored, and I asked my boss if I could help her with anything, and she decided that she wanted to do a forms project. Really, the idea of that was doing barcoding for scanning so we could have less errors. And to push our scanning vendor, we needed barcoded forms. We also had no forms committee at all. I guess when we went on Epic, we disbanded it, thinking we would be entirely paperless, and 10 years later, you know how that goes. We started researching all the forms in the hospital, and come to find out we have 2 different form vendors. We're paying out the wazoo for them, I'm sure. No one's designing anything internally, and no one's controlling anything, and we don't know what forms are out there. So we started inventorying them and then decided that we probably need a vendor. It would probably be a good idea to do electronic forms in some way. We ended up with FormFast, now Interlace. Thank you, Jason.
And you mentioned you're on Epic.
Yes.
What solutions of ours do you use?
With Interlace, so we have web form imprint, we do e-signature with Capture Client, we do FormFast Go, now Interlace Go, so that's that e-signature process with an iPad. We do Fast Flow Forms, which is like a premium e-signature form. We also have a custom-built downtime registration tool to kind of mimic Epic's registration. That way we could print out a face sheet if we were to go down. And then I would be remiss to say we also have managed form services with Tracy.
You all went live about 3 years ago with our solutions. Looking back on that go live process, what are some tips you could share with others who are looking to go live or upgrade in the future?
Yeah, so I listed out almost every single application that you guys have, and we kind of went live with them all nearly at once. So if your organizations are the same, an IT project is the time in which you have the most resources. So we pushed it from an HIM perspective. HIM in our organization is a part of IT, so we decided to push it from our side. We did not necessarily have clinical support. We kind of pushed them to say, you need better forms. And in doing that, we got an IT project manager. We had IT groups helping us, which meant our EMR support team, our IT trainers, and things like that. And not only that, but that's when you have the most vendor support. So I guess we decided to push almost every single one of those applications live at the same time because of all of those resource support that we had. And I would love to tell you all to don't do that. It was just, we went from pretty much January 1, we had no solutions, and we were talking to you guys. We were contracted then. And we went live on July 18th or something. So we went from knowing nothing to having almost all of those applications live in 6 months. So I would say that it was a little challenging, kind of being like a jack of all trades. I was the one doing form design with Managed Form Services. I was also the one doing learning all of these applications, creating all of the training materials myself. Even though we had support, it just, it was a lot to manage. And that go live week, I didn't sleep, it felt like. We even had our planned epic downtime on night 2 of our go live week. So we had immediate testing of that solution. So a lot to do. So I guess my tip would be to do smaller go live groups, do smaller go live units, maybe only one application at a time. But it's kind of proof of concept, and it's proven to be successful. It's just been a really big beast, and like I say, it's now part of my whole job. I became a manager of the group because of that project.
Did you go live in just... Is my mic on? Sorry about that. Did you go live in just one department or everywhere?
Yeah, everywhere. So we initially, we were talking to you guys, and we contracted as mostly a downtime tool. And then we through sales, got all of the other applications. So we were doing that proof of concept throughout the entire organization. So our hospitals we have 2 inpatient hospitals, and then we also have, at that time we only had 30, we probably had 40 PCP, primary care offices now, plus all of the specialty clinics. So we went live with every nursing unit, both hospitals. We did the e-signature with the iPads in the radiology department. We did e-signature with Capture Client in the admitting department and the ED, all that registration, all at once.
So what do you think is the best advice you can share with everybody here about how to look at each department individually and determine what solutions they need? Because it sounds like you bought them all at once, and then you sort of rolled out certain solutions in certain departments.
Yeah, so now going forward, when we're still kind of discovering who's not using the applications in the best way, or who could be using an application who's not yet, who could be using a more advanced solution, it's really hard for me to not introduce every single possible solution. So you could do this, and you could use this. You could use a Topaz, you could use an iPad, you could use a touchscreen, and you could use a premium form too. It's really hard for me to pull myself back and not introduce every single one of those options because I am, interested and passionate about pushing them. They get stars in their eyes too, and they start looking at what could be, and it takes, an extra 3 or 4 months to get us to that point, rather than let me understand your paper process, let me know exactly what you're looking for, and let me introduce one solution for you. And maybe we might have to pivot at some point, but rather than me walking in and saying, you could use these 4 different ways, and we could design your form and your form process in, an infinite number of ways, let's actually talk about just paper, and what does that mean to go electronic fully.
Great, thank you. So you talked about how January 1 you'd signed the contract, and by July you were live with all of the solutions. I assume that takes a lot of training, getting staff on board with the change. So what are some tips you can share about training that many staff members on new solutions?
Yeah, so we pushed it from an IT side, and we got buy-in from clinical groups, high level perhaps. We introduced it to them. We kind of understood the product from ourselves, and management of those groups always feel that tip sheets are sufficient or super user training is sufficient. And we discovered through all of those trainings that a simple tip sheet of a generic process of this is just what web form imprint is. Here, go out and prosper, right? You need specific tip sheets for a specific process for a specific audience, and that takes a lot of legwork on your trainer's perspective. Is I can hand somebody a tip sheet and they're like, okay, cool, this is a new website, but really they need to know, how do I print the MyChart form in this specific way for my patient at this clinic? So tip sheets are they're great, but we've really found that it takes way more at the elbow support, at least initially, and not only generic resource or training guides, but you need very specific. And to the point we're getting it's overwhelming, but we're getting to the point of we need tip sheets for every single form and almost every single process. I heard someone else mention a SharePoint site. So we do have an internal site where we put, like, this is what Interlace is, and this is what scanning is, and this is where all of your tip sheets are for printing forms, doing e-signature. We also have embedded videos, and now we're getting to the point of having interactive e-learning, so kind of like your yearly compliance training things. We put Interlace training on there as well. So at this point, other than clicking the mouse for them, I think we've introduced every single way that you could train somebody. It needs to be individualized, in my opinion, and I forgot to mention too, don't talk to just doctors. It's actually the office staff, and it's actually the nurses who are doing that effort. We got a lot of support from management and physicians initially, but they're not the ones that are doing the job.
Great. I love the tip for adding it to your annual training, because that's just the time where they're already focused on training, and sort of get that out of the way, and a refresher if they've forgotten some important steps. What are some other tips you can share for admins that you've learned in the last 3 years?
So web form imprint is, in my opinion, a pretty large tool, and staff don't always fully do things correctly. So we have a lot of forms that get hung up. Either they just forgot to hit the submit button, or they forgot one of the required forms on that field, and either they didn't hit done to realize that, or what have you. So every single day, my admin staff is going in and looking at every form open that should have been processed. We're HIMSS level 7, so everything has to get done within 24 hours. So we have admin staff, people in HIM and IS, that actually have to go in and launch every single form in progress to look at what wasn't done. Does it need to be printed because now a required field is not done and we don't have that person in front of us to do that? Or does it need to be deleted because they've, they had 2 different forms and they submitted the first one but couldn't do the second one, or they didn't know how to delete or something? It takes a lot of effort day to day at this point to look at all of those. And we're getting to the point of weekends is 200 some different patient lines that we have to look at. So I keep pushing you guys, like, please give me an easier way of looking at all those open forms, because we're getting to a point of an FTE just doing that on a certain amount of time. He also does form design, so he's busy otherwise, but there is a lot to look at. Is that good? Do I get it all?
I think so. You said you also had a process to look at forms from the perspective of, should this be digital or should it be on paper?
Yeah. So I just got reporting tools. I asked the right questions of my internal staff and Interlace, and we figured out a way to do reporting from a SQL statement. So we're now analyzing all of the printed forms to look at what forms are getting printed per month. So in August, we had 55,000 forms printed. And we're looking at what forms were already e-signature capable. So we're finding kind of the plot holes of where are an e-signature form implemented, but they're not using it. So the biggest one is our MyChart form. That might be because that patient doesn't have an encounter that day, so it needs to be kind of a blank form. Or it could just be that they're doing it at one of the desks that doesn't have a Topaz device, so they can't do e-signature. But of 55,000 forms, it was over 5,000 of those were our MyChart forms. And so now I'm kind of taking that to the IT groups to figure out, what would it take to make sure that we've implemented it in the right way, in the right desk, to have these be e-signature and not just printed. And then there are other forms that are getting printed off a lot of times that are not e-signature capable yet, and I guess that's probably where we need to look to next. So The number one example is our informed consent for surgical procedures. And, I've kind of keep kicking this can down the road because it's a really massive project. We do the informed consent for anesthesia for every procedure electronically, but not the surgical consent. And there's big reasons why. It's kind of hard to have both of those in play together. And also the surgeons want everything and then some when it comes to these forms. They want to do it in the office, not the day of surgery. They want to do it, they want to have all those drop downs, but there's 16,000 surgeries and an ever revolving amount of surgeons. So how do you implement that and make it easier for everybody? Not only that, but it's not the surgeons who are implementing those forms. It is the nurses who are getting them pulled up and trying to make that process work. So we can't just talk to one group and we can't just think of one, it's simple to say this form needs to be electronic. It's so much harder to figure out what is that process to make it electronic that would make it work for everyone involved.
Great, thank you. Any other tips you'd share with anybody or things coming up at Akron that you'd like to share with us?
Yeah, the next thing's coming up too is we've been live now for 3 years. So we implemented a policy. It was the same as our policy, I guess, where every policy has to be reviewed in 3 years. So we implemented the same thing for clinical forms. Every clinical form needs to at least get looked at and then kind of updated, so have a new revision date. So that's a massively daunting task when we've not even fully implemented every clinical form yet. We're 500 forms deep, I think, and we now have to start back up at the top. And if you guys aren't aware of the process to do this, is not only even if nothing changes on that form, but we want to say that this form has been looked at, we now have to submit it to Managed Form Services, get a new revision date, rebuild the PCL, update the merge, update the job, go through change control, because that's your IS process, and how many forms can you do at a time, and now we're starting all back over. So I think 500 forms is what we have, but it's more like, I'm going to just guess, 1,500 surfaces. So, 3 years in, and now we kind of feel like we're starting all over, even if nothing changes on that form. So if there were a better way to just simply update that form, then that would be really great. But, it's clinical forms, and it's a good chance that something needs to be updated anyway. But there is that big, massive project. And then I did mention the informed consent process, so just trying to figure out what that solution would be. And then the other reports that we're doing. So we were looking at all the printed forms. We also figured out a way internally, so Interlace, listen. We look at every single e-signature form that is processed. So we're looking at the background server, the temp backup folder. We organize that, and then we do analytics ourselves. So we're kind of organizing it of, which form got e-signed, how many per month, what were those forms, kind of looking at trend lines. That internal analytics is what helped us figure out that we had a massive spike of e-signature forms when it came to COVID, and Tricia loves hearing that story. So, we have good analytics, but it's all kind of homegrown reports at this point. So I know Eric Ballard's going to do some more reporting conversation, but, it's almost like we need kind of like that Power BI or BI Launchpad is what we call it. Like we need those more advanced reports to do more reporting to figure out where can we do and get a little bit better solution here.
Great, thank you. So as you can see, Rachel really is a forms guru. So we've got some time left to ask questions. So I think Patricia and Maggie can bring around mics if anybody has questions for Rachel specifically related to Epic or the different solutions that she's implemented. And she's also on our council, so we really appreciate all of the time she spends in helping us to improve our solution.
Mr. Wesley.
Thank you. So the SQL reports that you're running, are you creating the SQL reports yourself, or?
Eric wrote them. Eric Ballard wrote them. I'm just the one executing them.
Okay.
I have to change the dates because, like right now, the reports that we have in web form and print only allow us to do last 30 days. That's only perfect if you do it last 30 days at midnight on the first day of the month. So we had to do SQL reports to do actually, the first day of the month at midnight, the last day of the month at 11:59:59. So, I got special access to do read-only SQL server just so I could execute this. So, that would be a great thing if we could actually get that developed within web form imprint.
So, and that is something that our dev and product team are aware of, baking that into the new solution. They know that it would be very handy for you to have. And because of these conversations with Rachel, Eric is actually doing a session tomorrow on some reporting and things like that to kind of give you guys a few extra tips. So thank you for that, Rachel.
Perfect. Thank you.
What are you using FastFlow for right now? Like, is it just mainly clinical right now, or is it outside of clinical?
Oh, yeah, only clinical. So we actually only have one. Do we have two? We have two informed consents. So the informed consent for anesthesia and then the informed consent for interventional radiology. So we do have a case of informed consent for a surgical procedure when it comes to interventional radiology. So we have drop downs for the provider name, checkboxes that auto-fill in the risk, benefits, and alternatives. For anesthesia, we use that process because we have the parent and a witness sign and submit it, lock the entire form down, and then they pull it up in the OR. So the parent, a witness, and a provider sign it, they submit it, then they have to pull it up in the OR kind of as the ticket to ride. So they cannot start that until they actually do the timeout and they're over the patient and they know, yes, we have an anesthesia consent, let's submit it, let's start the procedure. So it's part of the timeout procedure. So we built a two-step workflow where they can fully submit the form, everyone can see it's ready to go, and then submit the form before the procedure starts.
Is there any reason why you didn't use Go for that by chance?
It was for the two-step workflow.
Yeah. Go
Because
can.
we had people, we just already saw on the horizon that people were going to submit it inappropriately before that second stage. So sure, you could fill it out and click save or just close capture client, but what happens if somebody hits submit? For us, with Go, with capture client, as soon as you hit submit, it goes in the background, it archives it. We have Highland on base as our archiving tool. So to go from web form imprint to Highland into Epic, it's right now about a 15 to 20 minute lag. And it's mostly on Highland's fault. And we can't figure out how to speed it up. And so the issue is do we look at it in web form imprint or do we look at it in Epic? What if we need to look at it within that 15 to 20 minute time frame? So no one would trust that it was actually done, so then they were going to do it again, which we didn't want.
So what would be your recommendation for informed consent? Would it be Go or would you recommend FastFlow?
We're using both. It depends on the workflow. So, that workflow is what we kind of used as a case study to see is flow better. I will say that the two-step process, originally it was 3 steps. So originally it was, have the patient and the witness sign it, hit submit. Then the next stage was have the provider pull it up, sign it, hit submit. The third stage was pull it up in the OR on an iPad. And what we were finding is almost every time that third step was not submitted. So it was on my admin staff to go in every single day, look at the surgery date to figure out was it yesterday, and then hit submit ourselves. So we had a come to the minds table meeting and say, can we get rid of the third step because you guys aren't doing it? So would I recommend it? Depends. I'm going to be a lawyer over here. It depends. That's where, again, follow the paper and do you trust your staff to do the right process? And that was always the challenging thing. It's not that we don't trust them. It's like, what if it didn't go well? And then even if it's the 1 or 2%, delaying the first case of the day impacts 18 other cases. So we kind of did that. And then the other informed consent we're doing with all the drop downs, our IR providers love that. So our normal informed consent only has mostly generic stuff on it. But the IR one, because it's so specific, it's a very specialized service that they felt that each IR procedure needed their special risks, benefits, and alternatives completely listed out. So them not having to type that out every single time, it just auto-fills in depending on what procedure they select. They love it. which I'm sure that's what our surgeons want to do. But I don't want to manage 50 informed consents, and I don't want to update it every single time they want to update a procedure. So I haven't talked to you guys yet because we haven't figured it out.
So Rachel said lots of good things, but something that struck me was follow the paper. That's a disconnect I see quite often, and I'm sure Tracy or any of our ICs can say that once you get on the floor and you do that discovery, that what people think happens and what actually happens are often two very different things. So follow that paper. Yes.
Talk to office and nursing staff. That was the biggest gap that we discovered, especially when it came to that informed consent process. We had massive buy-in by the anesthesiologists and the OR leadership, but the people who are actually doing the form are the ones who are most impacted, and that is honestly what delayed our go live a little bit. So hands-on training and talk to everyone who would touch that process.
Was there one more, or we're good? Okay, so thank you all, and thank you for being up here with me.